we are going to be doing some respiratory questions and see how they go. First up, we have a 72-year-old male presents to GP with progressive dyspnea, chronic cough. What's the question? Which one of the following is the most appropriate next stage in the management of this patient? All right, let's have a think. Progressive dyspnea, chronic cough, is 60-pack year smoker, and probably has some COPD. Spirometry shows FEV1 has 55% and FEV1 over FVC of 49. Okay, both are pretty down in his boots. The patient also keeps a peak flow diary which shows diurnal variation in readings. Which of the following is most appropriate next stage of their management? Is he on any inhalers? He's currently taking salbutamol inhaler. Alright, so I think we can probably step up that SABA to be I think they either go with LAMA or a LABA, I believe. Right, I think the next stage is to go a LABA or LAMA. So what are the options here? Or maybe I'll go both. I don't think we'll jump onto ICS straight away. So let's remove those ones. I don't think we will jump on the Montelukast straight away. I don't think we'll go leukotriene receptor blocker. Will it be this one? Let's see. Right, there we go. Maybe I need to go over some of my questions. Asthmatic features. Where's the asthmatic features? Diurnal variation. Come on, behave. Let's have a look. Correct answers. Significant smoking history. Obstructive picture. Yep, we got that. Patient, a history of atopy. Does it say he has X? History of atopy. Oh man, I'd say that's a bit of a cruel one, but fine. I know they have a little flow diagram down here. I need to go over. Sabarosama as required, asthmatic features, then we go for it as much as possible. Fine, alright. Next question. Chest x-ray. Okay. We have a 72-year-old male, presents with a 4-month history, increasing breathlessness, fatigue and weight loss. He is now retired but previously worked as a shipyard worker for 50 years. He has a 40-year back year history. On physical exam, clubbing of fingers on both hands. Chest x-ray is performed, and this is what is shown. Okay. So if we're looking at this chest x-ray, you can see the bases. There's no obvious consolidation. There is a bit of patchy haziness down the bases both sides. I don't think that'd be signs of specific cats from this. TB, you generally see more perihilar shadowing, so I don't think it's asbestosis or mesothelioma. I feel we are going to be going for mesothelioma with this one. I can't be certain why. Maybe because it's down in the lower lung as opposed to the upper lung, and it's more of a cancer-y picture with the weight loss. So let's see. Fine. Large peripheral mass on the list. Oh, it's talking about these. Okay. We got somewhere with some of the patient history, but we'll take it where we can. Alright. Let's go next. Now we have a 72-year-old woman diagnosed with COPD, history of progressive exertional breathlessness, and a productive cough. She has a 40-year pack here, smoking history, no previous respiratory history otherwise. Okay, so she has COPD. How should her treatment be escalated? Fine. So she has her salbutamol, but she continues to be troubled by her symptoms. Recent FBC was all normal. Okay, so it's saying that she doesn't have any asthmatic features. And she has COPD, not well controlled, just with a SABA inhaler. So we're either going to go LAMA or LABA. Let's see. I don't think we have to jump there. corticosteroid. I don't think so. I think those are the ones that we wanted. Let's go. Alright. That's just going down on Passmed's guideline, which has probably gone from somewhere. What do these people say? I agree that LABA and LAMA is the single best answer. However, alternatively, LABA and ICS is recommended by NICE. If there's a higher eosinophil count, which is not the same as eosinophilia. Okay, it said it was normal, but anyway, let's not get into the weeds there. SAB. Causes of them. Okay, normally we can get some good numbers on this. For each one of the following scenarios, please select the most likely diagnosis. 42-year-old smoker presents with a chronic cough and shortness of breath. Describes picking up copious amounts of sputum each morning. Okay. Chronic cough, shortness of breath. It sounds like his orthopnea each morning, maybe. Okay, well, a sign of it. And some curly bee lines, so it sounds like heart failure. A 71-year-old man who is being investigated for a current collapse during exertion presents with progressive SAB, pulse is 84, blood pressure 110/90. Alright, so he's collapsed. We're going to assume that he is not perfusing his brain, and that's causing the collapse for the low blood pressure, potentially. But let's have a little look at these. Okay, so he's got heart failure. I don't think so. We're not talking about any other things. It could be a bit of a pulmonary fibrosis. Yeah, I don't know. I don't necessarily know what this would be. Maybe the blood pressure might have to be higher though. Maybe that's causing it. I'm not certain with that one. A 73-year-old man presents with SAB. Smokes 20 a day, otherwise respiratory shows a restrictive picture. Okay, so restrictive picture, out of these, we're thinking pulmonary fibrosis, most likely. If there's nothing else, let's see. Alright, bronchiectasis for the heart failure. Parallel lines show, often called tram lines. Okay, fine. I thought we were talking about curly bee lines, but sounds like it must be a little bit different. Alright, let's see. What's up next? Okay, so we've got a 67-year-old man presents with progressive dyspnea on exertion. These symptoms have been getting worse. What's the question? Okay, respiratory diagnosis. Fine. Symptoms have been getting worse over the past 9 months, associated with a dry cough. He gave up smoking 20 cigarettes a day about 30 years ago. Doesn't really count then. On examination, his oxygen saturations are 97% on room air. Resp rate 14. There are some fine bibasal crackles. Finger clubbing noted. BNP is 88, so we're pretty reassured that it's not a heart failure. ECG, sinus 72, that's fine. Okay, so there's an obstructive picture going on here, or a restrictive picture, sorry. The ratio is elevated. So, it sounds like COPD doesn't cause clubbing. Idiopathic pulmonary fibrosis, I believe, does. Let's be talking about weight loss as well. No. Okay. And talk about primary hypertension. We're not talking about blood pressure at all here, so let's see. Yeah. Idiopathic pulmonary fibrosis. Let's go. This is typical hypathy of IPF. Male patient, of 50 to 70 years, presenting with progressive exertional dyspnea, clubbing restrictive picture on the respiratory. It's fine. We're happy with that. That's all quite straightforward. We now have what's the next management step. Okay. 83-year-old with COPD comes in, shortness of breath. This has come over 2 days. She is very wheezy, cannot talk in full sentences. Examination shows widespread wheeze and crackles. Her observations are as follows. Resp rate 30 a minute. quite high. O2 sats 92. She has COPD. FiO2 of 0.24. Heart rate 100. Blood pressure 115/66. Chest X-ray shows no pneumothorax. Okay, that's all we're gonna know. A patient is given salbutamol nebs and ipratropium, as well as oral steroids, probably some prid, about 30, I think 30 days. Anyway, she is given IV antibiotics and clarithromycin. She fails to improve after an hour of treatment and gets very tired. Okay, we're getting a bit concerned. Arterial gas is down at this point. The patient is on 24% O2. Okay. We know that normal atmospheric pressure is about 21%, so this isn't super high. By comparison, we know that it's going to be at least type 1 respiratory failure for low O2, and her PCO2 is elevated. So type 2 respiratory failure. So this is someone who's got probably an infective exacerbation of her COPD, who's getting a lot worse. I would call a senior because it would not make me comfortable doing the next step. So I think that's what you do after you're trying antibiotics. I don't know if we go IV hydrocortisone or aminophylline next. She's getting tired. It's hard to know. It was BiPAP. She's getting tired. She needs some assistance. Fine. And of normal. Therefore, this patient is a respiratory acidosis. We did get the pH. BTS guidelines suggest NIV. So she should have gone to NIV next. Oh, I'm into press there, yes. Right, let's see what's next. This question could be ambiguous for some. In many hospitals, NIV can be done in a HDU, ITU setting. Starting someone on an ITU-only therapy could be a bit dodgy. Okay. Alright, so I feel a bit less bad. I would have been like, send her somewhere with more support. But someone has a conversation with the 83-year-old about their own wishes and their escalation limits that are appropriate. This sounds like a very sensible opinion. This man's probably a med-reg. And that is a sensible take. Why is IVM aminophylline wrong? Shouldn't this be given prior to for consideration of BiPAP? I want to also know. Okay, maybe some other people are wondering. Fine. They are saying that she is. So the answer to that is type 2 resp failure, acidotic, so need to address that with ventilating her first. Yeah. What's the question? What is the single most important piece of advice to further reduce pneumothoraces? Okay. He's coming with a pneumothorax, I assume. 29-year-old, admitted sudden dyspnea, pleuritic, chest pain, heavy smoker, history of Resp disease, stop smoking. He considers himself healthy and plays regular rugby. On admission, he has a chest X-ray, shows pneumothorax, 3 centimeter rim of air, aspiration successful, and he's discharged. I think we were on the money. I don't think there's 12 months of avoiding flying. Maybe a bit less. But anyway, I think smoking's the answer for this. All patients should be advised to avoid smoking due to risk of further episodes. Lifetime risk of developing pneumothorax in a healthy smoking man is about 10%, with about 0.1% in non-smoking men. Fitness to fly may travel 2 weeks after a successful drainage. There we go. And 6 weeks. BTS recommend not traveling by air for a period of 6 weeks. Okay, but has now been changed to a 1 week post-check X-ray. Fine. Okay, stop smoking. Quite an easy one there. And now it's going to be the final one of the session. Let's see. Most appropriate management. 82-year-old man presents with 3-day history of a cough, productive green sputum, SAB. On exam, bronchi present, observations are stable. GP suspects acute bronchitis. Patient has a history of type 2 diabetes, managed with metformin and heart failure, for which he takes an ACE, beta blocker, and a loop diuretic. What is the most appropriate management? So this 82-year-old basically has a bit of an infection. I don't think he needs admission. Has he got any allergies? No. I don't think we'd Fluclox first line, Doxy. 2 first day and then 1 for the next 4 days. Yeah, okay. Antibiotics. That's not too crazy. Okay. Alright, that's all done there. Stomping cock.